All right, good morning, everyone. Let's get started. It's my pleasure to welcome you all to today's Region 4 Project Echo session from the Emory University School of Medicine's Serious Communicable Diseases program, run in conjunction with the Southern Regional Disaster Response System and the National Emerging Special Pathogens Training and Education Center. My name is Gavin Harris. I'm an infectious diseases and critical care physician at Emory University, Director of Outreach and Education here at the Serious Communicable Diseases program, or SCDP, and your host for today. Before we begin, please know that we will be recording this session and your data, while used for informative purposes, will be kept confidential. For those unfamiliar, ECHO is an acronym standing for Extension for Community Healthcare Outcomes, founded by the University of New Mexico. It's designed to disseminate and amplify best practices in an interactive and collaborative manner. And if you're interested in participating in future sessions, please reach out to us. Details will be at the end and on our website. As always, if there are any issues during the webinar, please send us an email or type in the chat. And if you'd like to ask a question during the session, please type it into the Q&A feature. We'll do our best to answer questions in real time, and we'll discuss as many questions live as we are able. If we don't get to all questions, we will post a recap addressing those topics on our website when the recording to this session is available as a podcast next week. These sessions are accredited for continuing education credits by the AMA and the ANCC. Credit can be obtained for attendance upon completion of a survey at the end of the session. The presenters and the planners of this session have no financial conflicts of interest with ineligible companies to disclose. And here's today's agenda. As always, we will start with the Region 4 SITREP. This will be followed by our case and didactic presentations with a moderated Q&A to follow. And now it's my honor to introduce our guest for today. Our case presenter for today's session is Dr. Jake Dunning, attending physician and clinical associate professor in infectious diseases at the Royal Free Hospital in London, England. He currently leads the hospital's Airborne and Contact High Consequence Diseases Service. Dr. Dunning is also Senior Research Fellow at the Pandemic Sciences Institute at the University of Oxford, where he has conducted both domestic and foreign research on emerging and high consequence infectious diseases at all aspects of preparedness, epidemiology, and care. Notably, he's previously served as the head of emerging infections and zoonoses, the enteric virus unit, and national incident director for the COVID-19 response for Public Health England, now known as the UK Health Security Agency. Welcome back, my mentor, Dr. Colleen Kraft, professor of medicine in the Division of Infectious Diseases, as well as professor of pathology in the Department of Pathology and Laboratory Medicine here at Emory. Dr. Kraft has had extensive experience in treating patients with emerging and high consequence infectious diseases. She's been deeply involved in the responses to the H1N1 pandemic in 2009, the West African Ebola virus disease pandemic from 2014 to 2016, Lassa Fever Virus outbreak in 2016, and COVID-19, having personally cared for patients with each of those pathogens. Additionally, for COVID-19, she led the Emory Healthcare system-wide coordination of diagnostic testing and has served on multiple committees from the local to state levels. Dr. Kraft is currently the medical director for Emory's Biocontainment Unit, or SCDU, and her research passion is in antibiotic resistance elimination utilizing microbiome-based therapeutics. Welcome to you both. And now, to place this session in context, the Emory University Serious Communicable Diseases program, in conjunction with the SRDRS, puts together situation reports on special pathogens of concern for our region, HHS Region 4. These SITREPs are typically published on our website, social media channels, Emory Department of Medicine YouTube channel, and listservs. Here is the current HHS Region 4 Special Pathogens SITREP. First, to Rwanda, where the latest Marburg virus outbreak was declared on September 27th. The last patient was discharged from hospital on November 8th, starting a 42-day countdown until the outbreak may be declared over, the last day of which is this Saturday, the 21st of December. Total confirmed infections stand at 66 with 15 fatalities, a case fatality rate of 23%, far lower than outbreaks of recent memory and largely a result of the swift and aggressive public health response. The Level 3 U.S. travel notice was lowered on the 27th of November, and on the 4th of December, the U.S. Department of Homeland Security and CDC ended the redirection of U.S.-bound air passengers from Rwanda to 3 U.S. airports, along with public health screening. Importantly, the majority of cases were among healthcare workers, highlighting the continued need for appropriate identification of potential cases. Next, to Nigeria, where Lassa fever virus infections continue. In the most current report that detailed the outbreak through the 1st of December, there were 140 suspects, 26 confirmed, and 5 fatalities, a case fatality rate of 19.2%. For the year, there have been 9,335 suspects, 1,115 confirmed, and 184 deaths confirmed, equating to a case fatality rate of 16.5%, comparable to prior years. As central Nigeria is set to enter the dry season, we do expect case counts to increase in the first quarter of the new year. Continued challenges include the late presentation of cases from poor awareness and health literacy, the high cost of treatment for the disease in Nigeria, and poor sanitary conditions in at-risk regions. And since the death of an Iowa resident on the 28th of October, there have been no secondary infections and evidence of additional transmission. While there were significant numbers of healthcare workers exposed, the majority of monitoring has ended. This was the 9th imported case of Lassa fever in the United States since 1969. Lastly, new cases of H5N1 continue to be detected in the United States. On Friday, the Louisiana Department of Health announced the state's first confirmed human H5N1 case in a person who was exposed to sick and dead birds and currently hospitalized, which the CDC confirmed on the 18th of December, the nation's first severe case. Importantly, this is also the nation's first avian flu infection linked to exposure to backyard poultry, not the strain currently circulating in dairy cattle. Thus, the nation's total this year is now at 61 in 8 states, but does not increase the threat level or the observed risk for human-to-human transmission. Lastly, LabCorp announced this week that their H5 avian flu molecular test is now available for order, further bolstering diagnostic capacity. We continue to closely monitor case numbers and reevaluate specific preparedness approaches. Healthcare workers in Region 4 are advised to remain vigilant in identifying potential patients at risk. And finally, there have been no reports of suspect or confirmed patients with special pathogens of concern in Region 4 at this time. For more resources, visit us on the web at scdu.emory.edu. All right, and now, as always, before we delve into the main topic at hand, I wanted to first pose some interactive poll questions to our audience to gauge our base comfort level with this topic. They should be on your screen now. The first question is, how knowledgeable do you feel about the current state of Lassa fever virus? And number 2, how confident do you feel about implementing the identify, isolate, and inform process as it pertains to Lassa fever? If the audience could please vote now. All right, if we could get the results of that poll up on the screen, please. And in terms of the first question, it looks like we have quite a range of comfort from not at all knowledgeable to very knowledgeable in terms of the current state of Lassa fever virus. And then in terms about confidence levels as it pertains to identifying, isolate, and informing patients who may have Lassa fever virus, we have quite a broad range of scale as well, from not at all confident to completely confident. So our panelists certainly have their work cut out for them. And with that, I'm going to turn it over to Dr. Jake Dunning.
Hi, thanks very much. I'll just share my slides with you. Can you see my slides okay?
We certainly can, yes.
Great. So I'm just going to move my menu so I can see them myself. And let's get started. So thanks very much for inviting me to speak. I'm going to discuss our most recent viral hemorrhagic fever incident in the UK, which was back in 2022, and was a family cluster of Lassa fever cases. So the first patient and the key patient I'm going to describe, the patient that I help look after, is the mother within this family. She was a 38-year-old woman at the time of presentation, with a fairly limited past medical history of gestational diabetes mellitus and also depression requiring some drug treatment. She, in terms of a social history, she lived with her husband and 4 children in the UK. She was born in Mali, but hadn't travelled back to Mali in West Africa since 2019. Otherwise, her travel history was unremarkable. To summarize her timeline, on the 10th of January 2022, we call this day 1, which was when her symptoms started, and she was 34 weeks pregnant at this point. By the 23rd of January, so this is 2 weeks later, she attended an urgent care centre at her local hospital, complaining of feeling more unwell. She was actually admitted 24 hours later to the same hospital in labour. Her estimated date of delivery was 13th of February, so she was almost 3 weeks ahead of her due date. She had a vaginal delivery and she was noted to have a fever with rigors during labour. Between the 26th and the 31st of January, with the 31st of January being day 21, she had fever, episodes of fever, fluctuating GCS towards 31st of January. She had acute renal failure with polyuria, and she developed thrombocytopenia with her platelet count dropping to 24. She also had a marked hepatitis with an ALT of 1082 units and also with a significantly elevated AST. She had CT and MRI imaging of her head in view of her fluctuating Glasgow Coma Scale. She also had, which was normal, she also had CSF studies which showed a few white cells, a few red cells, a low protein and a low glucose compared to her serum glucose. She had a serum sample sent to the National Reference Laboratory, but no clinical details were attached about her illness. By the 1st of February, it was day 22, and she was transferred to a regional neurointensive care unit in Cambridge in the east of England because of her worsening neurological status. So day 24 now, 2nd to 3rd of Feb, she's at the regional neuro ICU. She has a fluctuating GCS still between 9 and 13 with increasing confusion, agitation, and she's now anuric and requiring continuous venous hemofiltration. And she's noted to have marked hyponatremia as well with an EDIR of 125. Between the 4th and 8th of Feb, with the 8th of Feb being day 29, she was managed locally at the ICU as thrombotic thrombocytopenic purpura, TTP. She had an ADAM-TS13 level less than 10%, consistent with TTP, and that was treated with a mixture of plasmapheresis, caplacizumab, the anti-von Willebrand factor monoclonal antibody, and some methylprednisolone. Now, moving on to her baby, who was born a baby boy, born well at 36 weeks on the 25th of January. But by day 11, the baby was showing signs of sepsis, including fever, transaminitis, bloody diarrhea, and when the heel was pricked for blood glucose testing, prolonged bleeding was noted, although PT and APTT were found to be normal at that time. By day 13, the 7th of Feb, sepsis screens had come back negative, including a diagnostic lumbar puncture, tested for usual pathogens for neonatal sepsis, and hence the case was discussed with the Regional Paediatric Infectious Diseases Service in London and also with the National Reference Laboratory as well. The mother's illness was discussed, so noting that the mother was also septic, and then also the father's travel history and his recent illness were both revealed on the call. By day 15, the 9th of February, the baby had persistent seizures, severe coagulopathy that was unresponsive to treatment, and sadly, the baby died on day 15. The father's timeline, which was reviewed on the call on the 7th of February, revealed that he'd visited his native Mali between the 3rd and 27th of December 2021. He travelled around the Mandan region and other parts of southern Mali and had also visited the capital, Bamako. He'd visited mostly rural areas but had no contact with animals or any unwell persons and hadn't attended any funerals. He did see a traditional healer in Joliba for neuropathy affecting his right hand. He told us that he'd ingested some herbal teas and also had a traditional medicine of unknown source rubbed into incisions that had been made into his arm that was affected by the neuropathy. His symptoms started on return to the UK on the 29th of December, with non-specific fatigue, lethargy, myalgia, some loose stools, and also fever. He attended his local hospital on the 3rd of January, where he was admitted until the 6th of January. He received some empirical antibiotics for a presumed bacterial infection. Common infections were not identified. No diagnosis was made. He got better and he was discharged and made a full recovery. This just shows the map of where he'd visited with a red arrow showing the rural areas quite close to the Guinea border. The lower red arrow pointing upwards shows the village that he attended where he saw the traditional healer. In terms of diagnostics for all three cases, a decision was made to test the father's stored untested serum and also the mother's serum for viral hemorrhagic fevers using PCR assays at the National Reference Laboratory at Porton Down in the southwest of England. This was following that case call discussion. The following day, on the 8th of February, late at night, both the mother and father's results were through with Lassa Fever Virus RNA having been detected in both serum and plasma samples. This triggered activation of our UK High Consequence Infectious Diseases Network. On the 9th of February, the baby also had samples that tested positive for Lassa Fever Virus, and as mentioned, the baby died in situ at the neonatal intensive care unit at the local hospital the same day. That was a deliberate decision to leave the baby in situ because they were already moribund, and instead enhanced infection prevention and control measures were put in place with additional support provided by specialists. On the 9th of February, the mother was transferred to the principal high-level isolation unit for the UK at my hospital, the Royal Free Hospital. At our unit, we typically see one patient every 3 to 4 years, and our preferred method since the 1970s has been effectively to put the patient in the protective equipment. So the patient goes in what is effectively a plastic bubble. So here's shown the Trexler isolator tent, whereby we can become part of the walls through using the arms or entering one of the half suits. Item number 4 at the bottom is the supply unit that is connected to a large hole where the patient enters the tent, usually in an air transport isolator, a portable isolator unit, and then it's all sealed. The entire isolator tent is under negative pressure and the entire suite is under negative pressure and is in a secure area and is only entered by permitted trained staff. In terms of the mother's progress at the Royal Free, so on transfer, we'd prepared the unit overnight and also simulated admission of an intubated patient prior to her arrival. She was intubated locally just before the ambulance transfer, and she remained mechanically ventilated and continued to be hemofiltered for her acute renal failure at the Royal Free. On the 10th of February, so day 27 of illness, she started favipiravir treatment via an NG tube. Hemofiltration could be stopped on day 30 as it was no longer required. She then developed polyuria in her recovery phase. Vasopressors were withdrawn because no longer required on day 30. And on day 32, she stopped having fevers. She was extubated on day 33 and she received some antibiotics for a presumed ventilator-associated pneumonia. This graph just shows her antiviral therapy, which is initiated on day 27, as mentioned, or day 17 of admission, and was given for a total of 10 days. We didn't see any discernible effect on viral load in blood, shown on the left-hand graph for Lassa fever RNA. It was already, the CT value was going up, so the viral load was already coming down when we started treatment. Similarly, we're not convinced that it had an effect on influencing her defervescence either. Why did we give favipiravir? So there's some efficacy in preclinical trials against Lassa virus infection from in vitro and non-human primate models. There's also substantial use from other infections in humans. There's also local experience here of using it as post-exposure prophylaxis. We tend not to use ribavirin because of uncertain efficacy, particularly in those with ALTs of less than 150. There are various reviews, such as the one shown here, which question whether therapeutic levels can ever be achieved in humans compared to what can be achieved in animal and in vitro models. It has significant adverse effects in a large proportion of patients who receive it, and IV ribavirin is still quite hard to get hold of. Mother's outcome, she stepped down to the ID ward isolation room on the 24th of February, so day 41. At that point, she was still weakly positive for Lassa RNA in her urine, which we could manage because she was continent of urine. And we continued to use HCID PPE and IPC measures while she was on the ward in an isolation room. Her renal, hematological, and liver abnormalities were all resolving in her bloods, and she was discharged on the 4th of March, so day 49 after spending 39 days in hospital. Following discharge, she continued her what was thought to be appropriate grief reaction, but with worsening of her depression, and she also had significant fatigue, but thankfully she had no hearing loss. And there's just a picture of her. We had a BBC film crew filming at the time in the hospital, and they followed her home just to show her journey coming to an end for this illness, where she's back at home with her surviving children and her husband. So the key takeaways for us. So we know Lassa fever is the most common imported African viral hemorrhagic fever we've seen in the UK. We've had about 16 cases diagnosed and managed here since the 70s. And similar across Europe. And as you are all aware, cases are also imported into the USA. But overall, it's a rare infection in our context and setting. It's mild in most patients in Africa, but it can be severe and it can cause fatalities. And clearly, it can be transmitted between humans too. There are no proven treatments or vaccines currently. Good supportive care saves lives. That's true for all viral hemorrhagic fevers. I believe our patient would have died if she'd have been in Mali and had not had access to the physiological support that she got through intensive care unit type care on HLIU here. It's mostly seen in recently returned travellers in the UK and Europe. This is the first ever episode of household transmission that we've had in the UK, and I believe also in Europe as well. It reminds us to take a good travel history and also be aware of country-based ID risks, including risks of viral hemorrhagic fevers. And also, it was quite clever really here to expand the exposure history taking at the local hospital and with the regional advisory teams in patients with undiagnosed illnesses, particularly when a patient has a severe illness. Thanks very much.
Thank you so much, Dr. Dunning, for that excellent discussion of those cases. And now we're going to turn it over to Dr. Colleen Kraft. And while we're getting that set up, just as a reminder to the audience, if there are questions that arise, please feel free to put them in the Q&A feature. All right, Dr. Kraft, we can see your slides in the appropriate view.
Thank you. Thank you for the opportunity to speak on this, just sort of the epidemiology disease course in medical management. I think the case that Dr. Dunning presented prior really shows what we're trying to accomplish today, which is to understand sort of the epidemiology and the disease course so that we can recognize this before there are fatalities related to this. And this is actually a photo from Kenema, Sierra Leone, which is a regional hospital that actually specializes in Lassa diagnostics. It's fairly rural. It's about 4 hours from Freetown. And they have a whole Lassa hospital. They're also part of what helped diagnose Ebola virus disease in West Africa, since they were seeing sort of a different clinical picture than their typical Lassa patients. So as is already mentioned, we know that Lassa fever virus and its related clinical disease is endemic to West Africa, primarily found in Nigeria, Sierra Leone, Liberia, and Guinea. However, this has been found in other places. So I think, for instance, having somebody from Mali, we had a patient in our biocontainment unit in 2016 that was actually from Togo. And so these it is in West Africa, and I think it's important to remember that even if it's not been described in the area, that it may still need to be considered if it's in proximity to any of these countries. It's about 100 to 300,000 cases with a mortality rate of about 1%. And as is already mentioned by both Dr. Harris and Dr. Dunning, there's an increase during the dry season because of the rodent population and the aerosolization of their urine, if that's the way that it's transmitted for an individual versus person to person. Obviously, anybody that comes in contact with infected individuals are at risk. And the WHO is obviously actively surveilling just to prevent larger outbreaks. So once the contraction of a Lassa fever virus has occurred, and that's usually through contact with infected rodents or bodily fluids, there are very non-specific early symptoms. So anybody that lives in a resource-limited setting or in different areas with potentially less diagnostic capabilities, fever, headache, muscle pain, sore throat, and cough, for instance, is being manifest right now through the United States as influenza. Right. So that's a very non-specific presentation. So it manifests within 1 to 3 weeks of the exposure. So also that duration from the exposure does not also help in terms of figuring out if that's where you actually, thought that you may have contracted it. The disease progression is a lot of when these individuals then approach healthcare. And this can also be confusing because it's nausea, vomiting, diarrhea, and abdominal pain. There can be inflammation. Even though this is considered a hemorrhagic fever, that's not even an early symptom at all. And so then once it can affect the central nervous system, tremors, encephalitis, or seizures. And then you can have the bleeding sort of very late, and that's usually when there's much organ failure. So with proper medical treatments, the supportive treatment, usually patients can recover, but the fatality, depending on the region, can vary, usually depending on the level of supportive care. I don't think we can say this enough, but really recognizing and managing Lassa fever symptoms is crucial because I think early detection can significantly improve patient outcomes and spread this and the spread of this deadly disease. And so it's called Lassa since from the town of Lassa in Lassa, Nigeria, as it was isolated from the blood of a missionary nurse. And these are sort of the regions. You can see Togo in there is in proximity, as well as Mali, two areas that are really known to and count their endemic disease. And you can see this is another photo from Kenema, Sierra Leone, looking at how they have set up this was during Ebola virus outbreak and how they'd set up for different times for testing and for disinfection. And you can see in the back the diagnostic containers for how those the blood would be transported to the laboratory that was on site for PCR testing. So speaking of testing, there's a number of ways we can do these tests. Obviously, for some settings that have limited diagnostics, most of the cases in the United States are usually sent through their state health department to the CDC for testing. This is done by in-house developed reverse transcriptase polymerase chain reaction. ELISAs are usually, and this is again how the previous patient was kind of retrospectively found to have antibodies, or at least the husband was. And in some parts of the world, there are some rapid diagnostic tests, and virus isolation is very difficult because it requires intense culture techniques. But again, it may happen in places like reference labs. So most of the time, it's usually through ELISA, which is antibodies, or through PCR. Obviously, we know that there's surveillance and reporting, and I think it's really great to see how much the Nigeria Center for Disease Control has this Lassa fever surveillance system. I think it serves the region very wonderfully because, again, they can also know if they're in border areas or different areas that might be coming in from a different country. That's really important as well. So we've already talked about really all of these items up until antiviral treatment, which I'm going to cover in the next few slides. But obviously, isolation and infection control is key to these individuals to prevent the spread of the virus to healthcare workers and other contacts. we would always use personal protective equipment that's appropriate to minimize this transmission. And then what ends up happening, and again, this has improved over the years, is the contact tracing and monitoring. So we want to see if individuals who have been in contact with the patient have any, have any signs or symptoms, and they're followed basically until the incubation period of about 21 days has passed. It was truly amazing that the patient that was presented in Iowa with Lassa fever, despite having contact with healthcare workers, et cetera, that there was no secondary cases. I think almost 100 individuals were followed in that particular setting, and that really just speaks to how people are protecting themselves through PPE. And we're not really sure if, like, clinically he was that transmissible or they were that transmissible. And then always what's happening in the community, in these communities, is educating about Lassa fever and the preventative measures, mostly sort of the avoidance of having rodents cohabitating and doing things and activities that might aerosolize their urine that contains Lassa. So some of these things would be food storage, rodent control, safe burial practices, obviously early detection and reporting, and continued community education. So there's been an attempt to do some vaccine development. These are not given too often in ring strategies, but they are sort of being always considered as a possibility for large areas of outbreak. And although Dr. Dunning mentioned not doing ribavirin, I did want to talk a little bit about ribavirin. For us and our patient that we treated in 2016, we actually did ribavirin and favipiravir. Since really in resource limited settings and Kenema, for instance, they do use ribavirin still. I just quickly looked up, sort of how much that would cost, and ribavirin tablets are available the next day and are not very expensive. However, we don't really think they're of any efficacy in this particular illness, especially if someone's moribund, like was described. Inhaled ribavirin we definitely wouldn't use, but this is good to know how much this costs. It could be up to $70,000 and would be a next day delivery in the United States, but again, very expensive and not useful in this disease. So it leads us to ribavirin that's intravenous. And so that actually is only available through compassionate use in the United States. And so you'd have to initiate requests by contacting the Viral Special Pathogens branch at CDC. And again, as I've told you, we use a combination of favipiravir and ribavirin for our patient. He was not very critically ill. And so I'm not sure, again, if we can attribute his recovery to anything but supportive care. One thing I found as I was preparing for this talk is that the monoclonal antibodies that are being developed all over the United States and elsewhere all over the world to protect against Lassa fever virus has been an interesting story in and of itself. So, for instance, some of the strains that are different in the areas outside of Nigeria, such as Togo, and of course we have an interest in Togo because our patient had been living in Togo. They are not actually able to neutralize that virus as well as they are some of the previous viruses. So the antibodies that were developed against kind of the predominant strains of Lassa fever do not actually neutralize in non-human primates some of the other strains. And so I think this is going to be an area of interest for a long time as we're trying to figure out what are the best strategies to help these individuals. And again, this is really what you want to see. So this was Dr. Geisper and team's human monoclonal antibody therapy that protects. And this is the type of thing you want to see. You want to see a straight line of survival for those that receive the monoclonals. And then you can see the controls all end up dead from the disease. So you know that it was a pretty significant challenge. But again, this didn't happen in some of the differing strains. So we'll be certainly watching that to make sure that this doesn't get severe. So obviously, no new conclusions, but just to reiterate that early detection is life-saving and transmission preventing. And we still consider ribavirin as a mainstay of therapeutics, but monoclonal antibodies, favipiravir, other things are usually used. And so I'll take any questions at this time or whatever is next on the agenda.
Thank you so much, Dr. Kraft, for that excellent presentation. We're now going to move into our moderated Q&A portion for the remainder of this session. So once again, if there are any questions, feel free to type them into the Q&A feature as well as the chat. I'm going to begin with a question for you, Dr. Kraft, that's come through as I see we have some questions that are also appearing, but it has to do with more of a broad question. And for lack of better terminology here, I think one of the questions that people are having, especially in the United States, is why should we care about a illness that, you know, both based on your presentation, Dr. Dunning's, is quite rare, with a, you know, and especially in this country, relatively low fatality rate. So I'm just curious as to your thoughts on that, and then I'll turn it over to Dr. Dunning for his thoughts on that question too.
Yeah, so thank you for the question. I think that our world is becoming smaller, that flight and that we're a global community, whether we want to be or not. And so I think it's in some measure, there's a lot of different ways to look at it. There's an aspect of global defense, so really understanding what we're seeing and how to treat the patients that come in our hospitals in the United States actually protects the population. And I think in general, just because we've had some recent Lassa rule-outs that Dr. Harris facilitated in our region, I think one of the things that we're learning is that increased attention to a lot of these illnesses also leads to better diagnostics for the illnesses that they may have actually. And so we've learned a lot about through the Ebola virus pandemic and through other things that looking deeply for some of these actually leads to better quality of care, better supportive care, and also can lead us to treat the patient with effective therapeutics sooner because we're at that concern that it could be something that is transmissible.
Those are excellent points. Dr. Dunning, your thoughts. I know you've spoken on Lassa fever over the past several years since this incident for some time, but I'm curious as to your broad feelings as, you know, why this is such an important topic that we continue to discuss.
Yeah, I mean, I'm always mindful that the majority of Lassa fever cases occurring in endemic countries, or we should probably say at-risk countries, because the surveillance is a bit patchy and the map is changing, the risk map. But the majority of people who get it won't even know that they've had it or will only get mild illness and recover. But such large numbers of people get it that we do see severe cases. I'm sure there are cases of Lassa fever that go undiagnosed in the UK. There must be because of the spectrum of illness. And it's only the severe ones that come forward. It is the most common viral hemorrhagic fever that we see here, accepting that all viral hemorrhagic fevers imported into the UK are rare overall. For us, it's important because of the consequences of potential nosocomial transmission and onward spread. So that's why we want people to think about it, not go crazy, but you know, always just think if you've got someone in fever, particularly in a returning traveller, is a viral hemorrhagic fever a possibility? Provide them with the tools so that they don't have to carry all this information around in their head. So using online tools that outline country-based risks, for example, and make the diagnostics and advice lines available to them so that they can establish the diagnosis and implement infection prevention control as soon as possible. I think Colleen sort of touched on this, but the IPC is interesting because these cases that we've had in high income settings, they've often been multiple high risk exposures, including in healthcare settings before the diagnosis was made. So in our example, the mother gave birth, and there's probably a lot that universal infection prevention control measures do to prevent transmission of Lassa fever virus in particular. That said, you know, we're also aware of situations, particularly in Africa, where nosocomial transmission has occurred, including, for example, the Dutch missionary doctors who died in, I think it was 2018, 2019, whilst working in Sierra Leone after doing surgery on a pregnant woman. So the risk is there. It's always difficult, that rarity, but with the consequences of missing a case being quite significant.
Those are fantastic points. And just to get into some of the specifics to jump off on those last bits about diagnostics, could you perhaps elaborate on, when you have a patient you suspect of having Lassa fever, what are some of the differential diagnoses you don't want to miss, right? Because we of course always want to detect a zebra, so to speak, right? But we don't want to detect the most common things being common. And I'm wondering if you could elaborate for our audience things that you thought about and your team thought about with some of these patients.
Is that question for me?
Yes, for you, Dr. Dunning.
So we encourage people to follow our national algorithm and national guidelines, which makes exactly that point. Don't miss the common. And we tell them when it's safe to test for these things, even if you're suspecting a viral hemorrhagic fever. So you can still do a malaria test safely, subject to a local risk assessment. You can still put bloods up for culture so that you don't miss typhoid, for example. It depends on when the patient is presenting, what phase of illness they've got, and what symptoms they're manifesting as to what the differential diagnosis will be. But the differential can be broad and include common respiratory viruses because they may present with the fever, headache, myalgia, sore throat. It could be bacterial sepsis and typhoid. It could be leptospirosis. But most importantly for us, most of our suspected VHF patients turn out to have malaria. So malaria is the number one thing that we want people to think about, test in a timely manner, exclude and or treat. And in fact, we say if you diagnose malaria, it's outside of an outbreak situation, it's acceptable to treat them for malaria and see how they get on rather than immediately jump to viral hemorrhagic fever testing.
I'm going to turn to Dr. Kraft for a second, but before I do, Dr. Dunning, would you, in certain situations that are potentially high risk for returning traveler or for exposure situations such as what you've mentioned, while awaiting for diagnostic tests, for example, for malaria, would there be situations you would consider empirically treating for malaria while awaiting some of the results of the test to return?
I think if a patient was severely ill and you've got lab results and a clinical picture that would fit with severe malaria, then yes, it would be reasonable to start empiric treatment. Our malaria testing times here in pretty much across most big NHS hospitals are pretty good because we've got access to rapid tests and then also films, obviously, as well. So it shouldn't take that long to get a rapid test. And it's often easier to get the rapid test than it is to access the IV artesunate out of hours. So there's normally time to get the test result back.
Absolutely. All right, Dr. Kraft, I'm going to turn to you. So you mentioned, from your presentation, there's not really distinguishing features of Lassa fever that are really pathognomonic from other viral hemorrhagic fevers in some sense, or even for more common diseases such as we've been talking about malaria. With such a wide range of symptoms across the spectrum of disease with Lassa fever, do we have any sense of what populations might be more at risk for progressing to severe illness and disease, or does it relate to age of patients or things like that?
Yeah, these are great questions. It's difficult to know what leads to progression. We actually learned a lot about in Ebola virus disease, what led to progression during that time, because there were 28,000 individuals that were infected. Thankfully, with Lassa fever, we have much less of a cohort that get infected even annually. I think one of the things we don't know enough because we don't have resolution on the data is, did these individuals present late? Were they unrecognized? Were they in an area such as Togo, which isn't used to Lassa outbreaks? So I think it's very hard to answer the question. If I was going to be overly simplistic, I would say it's likely because of their ability and access to supportive care that leads to increased mortality. I can't remember what you asked me before the earlier question.
Oh, it was merely because there's such a range of, spectrum of disease. Do we have any sense of why some might progress to serious illness versus not?
Yeah, and I will say that in resource rich settings, I think that it's we're able to check things off as we see these individuals. So, malaria to me always should be tested first in anybody that's a returning traveler. And then, we can quickly get through a differential where it may look like it's different than typical sepsis. You don't always have that luxury, for instance, in Sierra Leone or in Kenema, where it is a bit more rural. They do have laboratory capacities, but they have laboratory capacities that kind of deal focused with Lassa. So for them, they can diagnose Lassa, but sometimes they don't have more diagnostics to say, well, this is typhi, or this is just, meningococcemia, et cetera. So I think in resource-rich settings, it becomes easier because we can rule out things quite quickly.
Understood. Great points. Dr. Dunning, there's one specific question that has arisen in the chat that I'm going to direct to you to before we move towards decedent management. And that is, in terms of the baby who unfortunately did not survive, pediatric management of Lassa fever, I assume, is quite challenging. I don't have personal experience with that, but I'm wondering if you could speak just a little bit as to how this was managed potentially in your unit, and if there are thoughts on maybe early detection might have led to a potentially better trajectory and outcome.
Sure. So in some ways, we were lucky that the mother was diagnosed after she'd given birth. If she'd been diagnosed antenatally, she would have come to my unit and we would have had to have worked out how to deliver her baby and then where the baby goes to receive care afterwards, because we're only an adult unit here. And a pediatric unit for London in the south of England has only just recently been commissioned. In fact, we've just done a major exercise to explore how we would manage antenatal diagnosis, delivery of the baby, and then extraction of the baby from our unit and transfer to another unit in a 3-day exercise, which some colleagues from Emory and other partners in NETEC were able to attend, which was great. I don't think there are any good data on managing infants and babies with Lassa fever. The data for outcomes come from Africa, so specific settings, typically low income, low resource with limited access to healthcare or background population health in many outbreak settings. And it's said that somewhere between 90 to 100% of babies born to mothers with Lassa fever, where the Lassa fever is known, so the mothers are more likely to be unwell, 90 to 100% of those babies will die. It's interesting, I think, that our baby was born well and died in the second week of life. So that's worth remembering as well. A well baby at birth, it doesn't mean that the baby isn't incubating infection and won't deteriorate. I think if we had diagnosed the mother antenatally and the baby was born well, we probably would have thought about using some sort of antiviral treatment in the baby. Again, there'll be limited data. We don't have a proven effective treatment for adults, so it's hard to know what we would use. I think I'd probably try a antiviral, possibly favipiravir, because we've got some experience of using that in young children. And if I could get hold of a specific monoclonal, I'd probably try that as well before the baby becomes unwell, and possibly even before we're getting positive PCRs back.
Thank you for I'm wondering if we could start with you. Oh, can you all hear me? I apologize.
Yeah,
Sorry, you froze for a second there, Kevin.
I'm sorry about that. I mentioned we were going to progress to decedent management at this time. There's been several questions coming in with regards to that. And Dr. Kraft, I'm going to start with you, and then we'll move towards Dr. Dunning. Any specific aspects of care that we need to think about when we're thinking of decedent management, given what we suspect is a progression of viremia as a patient unfortunately might progress towards death?
Yes, exactly. So if they're sick enough to be in sort of that fatality risk zone, they definitely have the most virus that they will have had throughout their whole disease progression. And then this also counts for, obviously immediately after becoming a decedent, that you would then be highly contagious because you would have sort of had, enough virus and progression that would have led to fatality. In fact, in our group in 2016 that one individual was transported to Germany before it was determined that he had Lassa. The mortuary worker that took care of him post-mortem actually contracted the disease. So it is something that, high precautions should be taken, like any hemorrhagic fever, in the care of the body after they're deceased.
Dr. Dunning, any specific antecedent measurements, measures that your team took with the baby who unfortunately passed away?
So yeah, we made that decision because the baby was going to die imminently by the time the diagnosis was made, not to move the baby to a high-level isolation unit, because we think they probably would have died en route, or shortly after. So it wouldn't have achieved anything. And we were able to provide assurance that enhanced infection prevention and control measures were in place with additional support from IPC experts to that local hospital, and also some sort of observation that the IPC was appropriate and was consistent to protect others in the hospital and wider public health. Once the baby had died, we pretty much followed what we do for adults who've died of viral hemorrhagic fever, which is focused on containment, accepting that viral load risk can be high. So using leak-proof body bags, double body bagging in the room, and then bleaching the outside of those body bags, and then they go into a casket in situ on site. So it's taken into a clean room, put into a casket with the funeral directors present, and then I think UK law requires the lid to be sealed on the casket before it's removed by an authorized undertaker. We only have one firm of undertakers who manages viral hemorrhagic fever deaths in the UK, and they've been doing it for a long time. They also did the Queen's funeral, if you're interested. So, same firm.
Well, thank you.
She didn't die of viral hemorrhagic fever, as far as I'm aware.
I was going to say, they took the words out of my mouth. So fantastic. They must be doing something right then. Fantastic. All right, we have about a few minutes left or so. I think it's time for some lasting thoughts. And just as a reminder to the audience, the resources from this presentation with the slides and the recording will be posted as a podcast next week, as well as, all questions that we were unfortunately unable to get to. Dr. Kraft, I'm going to turn to you and see if you have any last thoughts in terms of imparting advice to our colleagues here in Region 4 in terms of identification, isolation, and informing. One of the pieces that I'll say that I gleaned from your talk is really that optimized supportive critical care is the most important measure that we have in supporting these patients rather than any one specific medical therapeutic countermeasure. So with that, I'll just turn it to you to see if you have any other lasting thoughts.
Yeah, that's very clear. And I think, the sooner that you can think about it, if it's in your differential, then I think it helps steer you to what you need to be doing. And also, obviously, taking really good travel histories. So, fever in a returning traveler should always be malaria. That should always be tested right away. I think if you know that the location of their travel being West Africa, even without risk factors, clear risk factors that Dr. Dunning's patient had because they, in kind of looking through their epidemiology, he still had Lassa fever. So I think it's really just about, region. The clinical course tells you a lot, and then things that you have tested for, to rule out. Also tell you quite a bit about what you are to expect from that individual. I also put a paper about transmissibility of Lassa fever in the chat.
Absolutely, and we will be providing that to our audience next week. Thank you for that too. All right, Dr. Dunning, we'll close with you then. Any lasting thoughts on the topic of Lassa fever here?
Not really. I just expect to see more of it, I think, along with CCHF as well. I think many of the risk maps, the geographical risk maps, are going to change as we go forward, through climate change, but also through, I can't think of a word other than invasion of wild and natural habitats where a lot of the animal reservoirs live, and in this case, closer interactions with rodent reservoirs as well. So, yeah, I think I don't think they're suddenly going to jump in case numbers, but certainly as a specialist in this area, I expect to see an increased number of cases going forward, including imported cases into my own country.
All right, well, with that, I think that will end our discussion. Thank you so much to our panelists and to our audience. Before we close, I would again just like to pose an interactive question for our audience after participating in this session. Now, how knowledgeable do you feel about the current management and clinical guidance surrounding Lassa fever virus on that same scale from not at all knowledgeable to extremely knowledgeable? The question should be on your screen. If you could please vote now. And while we are voting, I just want to say thank you again to everyone and thank you to our technical team here at the SCDP ECHO. Yasmin Thornton, our outreach coordinator and leader extraordinaire, our planning committee with Sharon Benaresdale, Anish Mehta, Allison Claybar. Thank you. All right, if we could put the results to that poll up on the screen, please. And it looks like our panelists have made significant inroads. We have a shift in our spread here, which is absolutely fantastic. I hope you all found this session enjoyable and educational. For feedback and further information, including continuing education credits and the recording, please check the links here and on our website. We look forward to seeing you again soon. Stay vigilant, stay safe, and happy holidays.